Hello everyone, my name is Dr. Ominde. Discuss the cervical provide attachment for the ribs, so they definitely have costal facets over which the ribs attach or articulate. So we have typical thoracic vertebrae from the fifth have articular processes that extend vertically, and these facets are coronary oriented. Therefore, they define an intervertebral disc. Therefore, of the vertebral column. There's a greatest degree of rotation actually permitted between teeth. The thoracic vertebra has limited flexion, extension, and lateral flexion. Why? You need the rib cage to protect your organs in the thorax. You need limited of the rib cage on the thoracic vertebra. Lateral flexion. The facets are vertically oriented, and that limits movement. And then the spinous processes of thoracic vertebra overlap. So you need limited movement because of the lungs. So this is your thoracic vertebra. You can see the heart-shaped body. Okay, the spinous process that is elongated, so they actually overlap. Yeah, the spinous processes overlap, and then the trans processes and the will have articular surfaces of the rib. So you have costal facets on the vertebra. So that's when you come to T1 to T4, they have common features and some share with the cervical vertebra. So T1 is atypical thoracic vertebra. Why do we call it atypical? It's long and the spinous process is almost horizontal. Yeah, nearly as prominent as that of the C7 spinous process, which we call the vertebra prominens. Then it has a complete costal facet on the superior edge of its body, and that's mainly for articulation with the first rib. And then there's a demifacet on its inferior edge, and this usually contributes to the articular surface of the second rib. When you go to T9 to T12, they have features of the lumbar vertebra, so that makes them atypical. They have tubercles similar to the accessory and the mammillary process of lumbar vertebra. So most of the transition, as you transition from thoracic to lumbar region, they occur over the length of a single vertebra. So over the length of T12, you are able to notice the transition. So the superior half is thoracic in character, while inferior half of this T12 is lumbar in character. So what do we mean? The superior half has costal facets and the articular processes permit rotation, while the inferior half lacks costal facets and the articular process permit only flexion and extension. So that's what makes T12 a transition vertebra. Superior part resembles thoracic in character, while inferior half is lumbar in character. So thoracic to mean you have costal facet and you allow rotation, while lumbar character whereby you lack costal ribs and you permit flexion and extension only. So this vertebra is subject to transitional stress, and therefore it's the most commonly fractured vertebra, T12, because of these features. So what are the features of thoracic vertebra generally? The body is heart-shaped and has two costal facets for articulation with the head of the rib. The head of the rib articulates at the body. The vertebral foramen is circular and smaller than those of cervical and lumbar vertebrae. Why are they larger in cervical and lumbar? Because of presence of brachial plexus of the spinal cord and the lumbosacral plexus to the upper limb and lower limbs, respectively. The transverse processes of thoracic vertebra are long and strong and extend posterolaterally. And usually the length reduces as you go downwards. Then the transverse process of T1 to T12 have facets for articulation with tubercle of the ribs. T transverse process have facets for articulation with T tubercle of the rib. But the body had facets, costal facets for articulation with the head of the rib. The body articulates with head of rib, transverse process with tubercles of the rib. That is first to 10th rib. The articular processes of thoracic vertebra, the superior ones face posterolaterally, while the inferior ones face anteromedially. The spinous processes, we said they are long and they slope posterior-inferiorly, therefore they overlap. They get to the level of the vertebra below it. So T4 vertebra, the spinous process gets to as low as T5 level. Then we go to the lumbar vertebra. The lumbar vertebra is in the lower back between the thorax and the sacrum, and as you go downwards, at the lumbar region there's more body weight, so the vertebral body of lumbar vertebra are massive and they're thick, yeah, then the articular processes extend vertically. So the superior joints, the zygapophyseal joints in the lumbar region, the articular facets are sagittally oriented, okay? From T12 L1, they are sagittally oriented, and the inferior zygapophyseal joints are coronary oriented. That means they face laterally. Superior joints are sagittally oriented, inferior ones are coronally oriented, and especially L5S1 facets. Why is this information important? To tell you that there is more of flexion extension other than rotation. But in thoracic region, the articular facets were coronally oriented. So they were permitting more rotation, but less flexion and extension. When you get to the lumbar region, the superior facets are sagittally oriented, while the inferior are coronally oriented. Therefore, you have more flexion extension and you prohibit rotation. The transverse processes in the lumbar vertebra, they project posterior-superiorly and laterally, and they have facets, or rather, they have a surface for attachment of intertransverse lumborum muscle. Lumbar vertebra also have mammillary processes, and these are for the attachment of back muscles such as multifidus and medial intertransverse muscle. So lumbar vertebra has a kidney-shaped body. Cervical had no body. Thoracic had heart-shaped body. Lumbar has kidney-shaped body. Okay? You have your transverse processes here. In thoracic, the transverse processes had foramen transverse area. Then look at the superior articular facets and the inferior articular facets. So we said the superior articular facets, they're sagittally oriented, while the inferior are more or less coronally oriented. Then look at the short spinous process and and the mammillary body here. Okay, so L5 vertebra specifically, this one here, fifth, it's the largest of all movable vertebra, and it carries the weight of the whole upper body and transmits it to the sacrum. So it has a very massive body, and its body actually projects deeper anteriorly. Therefore, it's responsible for the lumbosacral angle. So when you draw an axis through the lumbar region and an axis through the sacral region, you form the lumbosacral angle. Okay, so this is the lumbosacral joint between lumbar and sacrum, and a long axis of the lumbar region to that of the sacrum together, it will form the lumbosacral angle. So the body weight is transmitted from L5 to S1 vertebra. What are the features of a lumbar vertebra? The body is massive and kidney-shaped, as you view from superior. The vertebral foramen is triangular and larger than the thoracic because of the lumbosacral plexus, but it's smaller than that of the cervical. So the cervical has the largest vertebral foramen because the brachial plexus are big. Transverse processes of lumbar are long and slender, and they contain accessory processes on the posterior surface. Then articular processes, the superior ones face posteromedially, while the inferior ones face anterolaterally. Then the spinous processes are short and sturdy, and they're thick and broad. Thick, broad, short, and sturdy. So you need to understand all this. For medical students, we'll bring a vertebra in your practical exam, and you should be able to say, this is a lumbar vertebra because it has a kidney-shaped body, which is massive. It has a triangular shaped foramen, vertebral foramen. It has superior facets facing posteromedially and the inferior ones anterolaterally, and the spinous process is short, sturdy, thick, and broad. So for each vertebra, you need to be able to know at least 5 features that justifies or describes it for your practical exam. What are the applied aspects? There is lumbar spinal stenosis when the vertebral foramen is narrow, and this can compress the spinal cord and the spinal nerve roots. So how do you decompress? If it's narrow, you can decompress by what you call laminectomy, where you go and surgically you access the vertebral foramen through the laminae. Then we can discuss the sacrum. It's large and triangular wedge-shaped bone where you have your 5 sacral vertebrae that have fused. This sacrum is connected to the hip bones at the sacroiliac joint, and it's triangular in shape and due to rapid decrease in the size of the lateral masses. So as you go downwards, the lateral masses decrease. So the lateral mass of S1 is more than S2, which is more than S3. So as you go downwards, the lateral masses decrease, therefore giving it a triangular shape. Remember, the sacrum, the inferior half of the sacrum, is really not weight bearing because the superior part takes the weight to the through sacroiliac joint to the pelvic girdle. The sacrum provides strength and stability for the pelvis, and it also transmits the body weight to the pelvic girdle. There is usually a sacral canal which corresponds to vertebral canal, and this houses the lower spinal nerves which form the cauda equina. So we have 4 pairs of sacral foramina on the anterior and the posterior surfaces of the sacrum. So these allow an exit point for posterior and anterior rami of the spinal nerves. So you have the foramina on the anterior part of the sacrum, which are the pelvic foramina. They're usually larger than the foramina on the dorsum aspect of the sacrum. The sacrum has a base. This base is at the top at S1 vertebra, and then it has articular process that articulate with L5 vertebra. And remember, the first sacral vertebra, the anterior part projects inwards and forms the sacral promontory. And this sacral promontory can actually be palpated during obstetric examination, digital vaginal exam. As you put your fingers through the vagina when a woman is lying supine, you can actually go deep and be able to palpate the sacral promontory in pelvimetry, where you're trying to check whether the diameter of the pelvis is adequate enough for fetus as you prepare for delivery. The apex of the sacrum usually tapers inferiorly, and it has an oval facet for articulation with the coccyx. This is what we've just described. You have 5 sacral vertebrae that are fused, and it's triangular in shape. The sacrum is triangular in shape because the lateral masses reduce as you go downwards. You have sacral foramina, 4 pairs, and they are larger on the pelvic surface than on the dorsal surface. So this is the dorsal surface. You can see spinous processes fused to form a median crest. Okay, then you have your intermediate sacral crest, the sacral canal for cauda equina. Okay, and then this is the base of the sacrum is at the first sacral vertebra, and the anterior portion that projects into the pelvis is the sacral promontory for obstetric purposes. And we say the sacrum has auricular surfaces that make it able to articulate with the iliac bones. Okay, and then this is your tailbone S5 articulating with the first coccyx and the coccygeal vertebra together joined to form a coccyx there. So the sacrum is usually tilted, articulates with L5 at the lumbosacral angle, which is usually 130 to 160 degrees. The females have a wider sacral length than the males. The males have a larger S1 body. So the pelvic surface of the sacrum is usually smooth and concave with transverse lines that indicate fusion of the sacral vertebra. So during childhood, the sacral vertebrae are connected by hyaline cartilage and are separated by intervertebral discs. But later on, fusion of sacral vertebrae starts at the age of 20, and most of the IV discs remain unossified up to or beyond middle life. So the dorsum of the sacrum is rough and convex with 5 ridges, a central or median sacral crest where the spinous process is fused, an intermediate sacral crest where articular process is fused, and 2 lateral crests where the transverse process is fused. So transverse processes form lateral sacral crest, articular processes form intermediate crest, and the spinous process form the median crest. Then we have a sacral hiatus. Sacral hiatus is where you have absent lamina and spinous process of S5 and S4. So it's formed by absence of lamina and spinous process of S5 and S4, and the hiatus actually leads to the sacral canal. The depth of this hiatus usually varies depending on how much spinous process and lamina of S4 are present. So the hiatus sacral hiatus results from absence of the laminae and spinous process of S4 and S5, and it leads to sacral canal. So this is the sacral hiatus. Okay, this is your sacral canal. So sacral hiatus results from absence of laminae and spinous processes of S5 and S4 down there. So it directs you to the sacral canal, and the depth varies depending on how much of the spinous process and laminae are present. Then we have the sacral conua, which is represents the inferior articular process of S5. So usually this conua projects inferiorly on each side of sacral hiatus. Articular surfaces of the sacrum on the lateral aspect, they form the auricular surfaces for articulation of the iliac bone, so to form the sacroiliac joint. And this auricular surface is usually covered by hyaline cartilage. So what are the applied aspects? You can apply anesthesia, local anesthetic agent. You can inject into the fat of the sacral canal so that it gets to the sacral nerves in the chordae equina. But how do you inject? You have to palpate the conum. This is the sacral conum. When you palpate it, it directs you to the sacral hiatus, where you now inject your local anesthetic, and you're able to affect the spinal and coccygeal spinal nerves of the chordae equina. So you palpate the conum that acts as a landmark to tell you where the hiatus is. And remember, we say the hiatus is formed because of when you have absent spinous and lamina of S4 and S5. You can have abnormal fusion of vertebrae, hemisacralization, yeah, or sacralization of L5. Instead of L5 to be part of lumbar vertebra, it goes to join and it's incorporated into the sacrum. Okay, then the L5-S1 level becomes strong, while the L4-L5 segments can degenerate, leading to pain. You can also have lumbarization of S1 vertebra. Instead of S1 vertebra joining other sacral vertebra to form sacrum, it fails to join, so it's separated from the sacrum and is partly or completely fused with L5. So look here, L5 is not supposed to be part of this triangular sacrum. This is where there's a rib, this is T12. So this is L1, L2, L3, L4, L5. So this is sacralization. L5 has been joined into the sacrum. So this is sacralization. And when you check here, this is your L5. It has been undergone sacralization. Then coming here, this is your T12, L1, L2, L3, L4, L5, S1. S1 is separate from the rest of the sacrum. So this is lumbarization of S1, and this is sacralization of L5. Again, look here, S1 is very separate from the rest of the triangular sacrum. This is L1, L2, L3, L4, L5. So S1 has been lumbarized. Then you go to the coccyx, which is the tailbone. It's triangular. The four coccygeal bones fuse. And the first one may be separate. And remember, the coccyx is a remnant of the embryonic tail. So the pelvic surface is usually smooth and concave, while the posterior has rudimentary articular process. So the first coccygeal is larger and the broadest and has short spinous processes. And its rudimentary articular process forms the coccygeal conum that articulates with the sacral conum. Remember, the first coccygeal fuses with the sacrum with increasing age, and the last three coccygeal vertebrae fuse during midlife, therefore forming the coccyx. What are the functions of the coccyx? Remember, they don't support the body weight when standing, but when sitting, the coccyx may flex anteriorly and receive some body weight. So it may receive some body weight while seated, but not while standing. And the coccyx also provides attachment for various muscles such as gluteus maximus, coccygeus muscle, anococcygeal ligament, and the median fibrous intersection of the pubococcygeus muscle. So coccygeus, pubococcygeus, anococcygeal ligament, and gluteus maximus attach onto the coccyx. So this is the base of the coccyx. You can see the transverse process of the first coccyx. Then the other three coccyx will join. This is the apex of the coccyx. Anteriorly, it's concave and smooth. Posteriorly, you can appreciate some ridges. Again, this is first, second, third, and fourth coccygeal, and you can appreciate the coccygeal corner articulating with the sacral cornea. And we say the sacral cornea, when you palpate it, it directs you to the sacral hiatus, which is formed by lack of spinous process and lamina of the S4 and S5 vertebra. So injury of the coccyx when you fall onto your lower back can lead to subperiosteal bruising and fracture of the coccyx, and this can lead to dislocation at the sacrococcygeal joint. The coccyx may be displaced in these cases of fracture, so you have to do surgery to remove the fractured bone. In difficult childbirth, you may injure the mother's coccyx. Again, we have what you call coccydynia, coccygodynia. So coccygodynia is a syndrome where in coccygeal trauma, coccygodynia is a troublesome syndrome after you've had trauma to your coccyx. So coccygeal trauma causes coccygodynia. So it's pain around the region of the coccyx. We call it coccygodynia. Other applied aspects of the vertebral column, you have cervical ribs. These are, instead of ribs being in the thoracic region, you have ribs in the cervical region and mainly at C7 region. Then this may vary in size and they may be supernumerary or extra, where you have a rib or you can have a fibrous connection from the tip of this rib to the first thoracic rib. Now, why do you need to know about these cervical ribs? They may go and narrow your thoracic outlet, leading to thoracic outlet syndrome. So you're going to compress the structures of the thoracic outlet, leading to compression of subclavian artery and inferior trunk of the brachial plexus. So cervical rib, for example, we've said the ribs are supposed to be in thoracic region, but when you have a rib on C7, this is the cervical rib and it's attached onto the first rib by connective tissue. So this is your thoracic outlet or thoracic inlet. It's usually formed by first thoracic vertebra, posteriorly, the first rib, and the manubrium of the sternum. So this forms the thoracic inlet. Usually you have the brachial plexus and the neurovascular, other vessels, subclavian vessels, for example. So this cervical rib can come and narrow the thoracic inlet further, leading to compression of subclavian artery and inferior trunk of the brachial plexus. And that's what we call the thoracic outlet syndrome. What happens with age? From birth to 5 years, the lumbar vertebrae increase in height. 5 to 13 years, they keep increasing in height. At adolescence, there is continuous longitudinal growth. 18 to 25, you start decreasing the growth rate, and you achieve the growth rate by the age of 25. But when you get to middle and older age, what happens? Bone density reduces, and the IV discs become increasingly convex, and the articular surfaces become increasingly concave. So with age, bone density reduces, articular surfaces become concave, IV discs become convex. So aging, there's increase in compressive force at the periphery of the vertebral bodies and the zygapophyseal joint, leading to osteophytes. Osteophytes are just bony spurs that form at the peripheral part of the bones and joints. Okay, so you can see here, so this is normal spine, everything looks smooth, the outline is okay, but with age you have what you call osteoarthritis. The bone density reduces, you form bony spurs. Compare this and this smooth outline. So bony spurs, which we have referred to as osteophytes. So these are the bony spurs. The disc space has been narrowed. Look at this disc and this one. It has been narrowed. And if you're to look at the margins, the articular surfaces, they become concave or cup-shaped. Compare this and this. Okay? So those are the changes that occur with age. So next lecture we'll discuss the joints of the vertebral column.